This conference will now be recorded.
Yeah. So most of the accidents will be life-threatening, but not all. Few of most of the trauma cases will not be life or limb-threatening, but severe trauma can be a major cause of death. It is the fourth leading cause of overall death. And again, if you see in young age group, it is the leading cause of death. It could be suicide or homicide also. Okay. And in older patients, mostly they'll have trouble with fractures because they have weaker bones. So that is a burden again to the society and healthcare system. So trauma, when does it come? We all know that primary prevention is there, secondary prevention is there, and tertiary prevention. You know what primary prevention is before the disease even comes. Early diagnosis of the disease is secondary prevention, and trauma management comes as tertiary prevention. Okay. That means after the injury, you try to elevate the secondary causes. So it could be better if we are able to do a primary prevention in few risky individuals, like in adolescents where people are 16 to 18 or 14 to 18, where they're given motor vehicles and under the influence of drugs or alcohol, or just because of inexperience, there are a lot of motor vehicle accidents in this particular age group. Okay, so as a doctor, what do? We get patients in your emergencies or on the field. You see this trauma cases. How do you react? Okay, so the additionally, what we are trying to learn when we are speaking specifically about trauma is an approach. Approach is different. Otherwise, everything is similar to what we have learned in anatomy and physiology. But here you treat the life-threatening injury first. You're not going to treat the things that you know, but you're going to treat the things that you know will cause death. Okay, so the priority is shifted to the life-threatening injuries. Okay, one is to diagnose them as fast as possible and simultaneously start the treatment for the life-threatening injury. So everyone has their own idea. So things can be missed. So that is why we have a systematical approach, which was concised by American ACS, American College of Surgeons, in a committee on trauma. Okay, so they have come up with a system called as ATLS. ATLS means Advanced Trauma Life Support. Okay, you might have known about BLS, Basic Life Supports. In BLS, what do we learn? We learn about how to do effective CPRs. Okay, an effective CPR is 100 compressions per minute, and you have to give 2 breaths per 30:2 ratio. Okay, compressions are more important. In to call it an effective CPR, it should, if you're doing it for 10 minutes, 85% of the CPR time should be of just compressions. Your 1.5 minute rest should be about checking the pulse, stopping for any other reason, for even shocking. So compressions are the most important one, and compressions are most effective when you have a chest inward drawing and chest you have to relax out. Okay. So in the management of trauma, they have envisioned that not all doctors are equipped with trauma. Not like, suppose if you're doing pediatrics, or maybe you're doing general medicine doctor later, but you have come across a trauma. So the trauma is important to be inculcated in your MBBS and you're in the post graduations, so that you will be able to have a you will be able to treat the patient or stabilize the patient before a definitive procedure. Okay, so what is the significance of time and the outcome? So basically, we have been talking about life-threatening, life-threatening. Keep on repeating the term called as life-threatening, limb salvage, limb cannot be salvaged, and all this. So why is time important? In some, so the the person, if he's traveling in a car and is very good, just the seconds before his injury is called as time zero. Okay, and immediate the impact of injury has happened, and from then the body's response to injury, and the patient coming to hospital and the doctor initiating some kind of treatment to stop the adverse reactions, adverse consequences. So this is all your timeline. From the time of injury, your timeline starts. Seconds before the injury is called as time zero. Time zero, you are stable. That means injury has not happened. After at T1, injury has happened, and from then on, it is your timeline. Timeline will vary. Okay, in some cases, people will can die suddenly, in less than 5 minutes or in less than 3 minutes. That means they have very severe trauma, which is most likely cardiac or a vascular component or a severe CNS trauma. Okay, the shock, hemorrhage, and everything, the people can survive for hours. Pneumothorax, tension pneumothorax. So people will survive for a little hours because it takes some time to develop. So these people, you can help them if the patient is brought in 20 minutes to hospital or 30 minutes to hospital. Always remember this this time, that where it is valuable that the patient is brought to a treatment room or an intervention where it happens is called as golden hour. This is usually the time taken for the patient, earliest time taken for the patient to reach the care trauma center. It's called as golden hour. It does not mean it is 1 hour. Okay, golden hour can change. It is not fixed to 1 hour. Okay, because you also need time once the patient comes. So the overall timeline for generic injury is assessment time and response time. Okay, so once you have checked all this, how will you assess the trauma? The trauma has to be assessed in your mind. You have to analyze that. You have to remember that a small equation. First, I'm going to line by line, I mean topic by topic of your Bailey. Next, I'm adding few points to that. That's all. Okay, you can read the Bailey first two of part 4. Okay, trauma. In assessment and response, the patient, you have to see that with an equation called as patient plus injury is equal patient plus mechanism of injury is equal to the outcome. Okay, that means if the patient has fallen, patient normal, how the patient is, plus the fall, you should expect what outcome is, like what kind of fracture he can have. If a pediatric fall, if it is a small kid who falls down while walking, say maybe 3 years, he's falling and he has a small trivial injury, which one will fall first? In adults, usually the people will try to save themselves, so they might put an elbow or fall on an outstretched hand. Usual in kids, it doesn't happen. In kids, usually they strike the head first because of their center of shift, cephaloid direction of their center of gravity. Head is heavy, right, in kids, and the proportion of head is more than their body. So in pediatric trauma, that is a little different. So you have to analyze that. Whenever you feel that patient plus injury is doubtful to the outcome, that means the outcome is more severe than what is the injury that the patient has been telling you or the patient attender has been telling you. Then you'll have to understand that either one, the patient is lying or the patient attenders are lying, and there is a criminal point of view or an abuse point of view there. That is your suspicion, or it could be a hidden injury that you have not found or you have not seen. Okay, so always remember, you need to know first, initially after patient comes, you need to do a quick clinical examination. I'll tell you about what clinical examination, what is that survey called as, I will tell you in some time. So after the clinical examination, it is important that you analyze the interaction between the patient, the mechanism of injury, and the extent of injury sustained. Okay, I'll keep using the word extent of injury as outcome. Okay, so you should remember that the patient and an injury is equal to outcome. So you need to know what kind of energy has been transferred. When we are talking about energy, you know that energy cannot be created nor destroyed. Energy can only change forms, right? So in any kind of accident, so why are we standing? Why are we not floating or flying? Because of gravitational force, right? So always one kind of energy has been acting on us. If we are sticking to the ground, it does not affect us. But if we are falling, or if you are falling from a height, gravitational force is employed. That so the laws will be there. What is force is equal to ma, mass into acceleration, or mv, I think, right? Okay, so these things are important. So in motor vehicle accidents, you have to particularly understand how a head-on collision can happen, how a T-bone collision can happen. T-bone is on the side like a T shape. One car is going in one direction, the other car comes in perpendicularly crashes into the side of the car, and another one is if you're stopped or if you slow down and some vehicle comes from behind and hits you. So what are these kinds of impact? Or if the it's a rollover injury, how will the impact? You have to imagine that the force of one car is transferred to the another car, right? If it is a head-on collision, you should understand that both are coming from in different directions. The force of this and the force of this will become summated, will add up, because if they come to zero, or if they come push each other away, so that kind of energy is transferred into something else. It is not absorbed entirely by the car. You should also remember that if a force is there, if for a better protection, the car has to give away at some point, because that way the force is not transmitted to our body. One more point you have to remember is, you remember the Newton's law, law of inertia. So in our body also, once we sit in a car, we keep on going at 90 speed. Our body is also actually traveling at 90 speed. So whenever we put to a sudden brake, the points that are fixed in our body will continue to go at be at the speed of the car, but the points that are mobile will take some time to reach back to its the state of the fixed points. So we will have a problem in mobile and fixed regions. The disruption of force between the disruption of force between the fixed and the mobile points. So suppose one structure is attached to one place and not attached to one place, and if you keep on swinging it, that means you at one point the energy is more, and at the point the energy is in a different direction, the force is in different direction. So wherever it is fixed, it can cause a tear. So this explains how iota can also be teared in a deceleration injury. Okay, so there are different kinds of mechanisms how the injuries can happen. So basic, if you bring all of them into broad classification, you can say that it is blunt or penetrating or combined. Okay, blunt mechanism, penetrating mechanism, or a combined mechanism. These are a very broad mechanisms. Okay, under that you can add more things. In a direct mechanism, the damage is localized to the site of injury. In contrast, in an indirect blunt trauma, I'm talking about blunt trauma, they have again two components, direct and indirect. Direct is where you hit it. Indirect is at a distant place after transmission of the injury. Okay. Now, if you want to understand this, there are some examples that have been given in your Bayesian law. You can read the 314 point. Apart from that, they talk about how a sharp object is there and all that. So when we're talking about sharp objects, you have to see the weapon is more important, the instrument is more important. In sharp objects, you will have to see, suppose say for example, knife stabbing injury. Patient came with stabbing injury in the chest and in the abdomen. So the length of the knife or the sharp object is involved. You should know, and the knowledge of the local anatomy is essential because you need to see what could have been affected. And you should remember that the abdominal structures at risk of injury can extend high up into the chest. Like in your substernal, if you palpate your substernal, if there is a stab injury in the substernal, you can feel that if the person stabbed it could be of your abdomen, because your abdomen goes as high as fifth rib in your expiration. Okay. Apart from that, there are high velocity injuries like bullet injury. In a low velocity bullet injury, always acts like a knife. In high velocity bullet injuries, there are something called as you'll have a concept called as permanent cavitation and temporary cavitation. You have to remember that permanent cavitation is something that already is formed by the trajectory of the bullet, and the temporary cavitation is because of the energy transfer of that high velocity moving object, causing dissipation of energy. So that kind of energy or that kind of molecules, the molecule, what does we have? We have cells that contain water, which gets heated up, and because of that heat, the temporary cavitation forms, and again it can close up on itself. So when it is closing up, or when this reaction happens, there is a chances that the gunpowder, the or in case of bullet fragment, or can get dislodged into this temporary cavitation. So temporary cavitations can contain foreign bodies, okay, foreign material. So coming to this, what is the how will you in different patients, patient factor is also there. I've told you, like pediatrics, the center of gravity is shifted to cephaloid, and in adults it is more towards the abdomen. Okay. And also again you need to remember there that the kids are very short and adults are taller. So in motor vehicle accidents, so suppose the pedestrian, compare this situation or analyze this scenario where an adult and a child is walking on the road and has been hit on by a car. So the impact of the car, or the impact of the car on the adult is versus the impact of the car on the pediatric patient. Say suppose 5 years is there. So in adults, usually the patient will get hit near the kneecaps or a little below, and the patient can fall onto the bumper. Head will hit the windshield or the front bonnet. Okay. In while in your pediatrics, the bumper of the car can hit the pelvis, and the kid can be thrown out, and the person will land on his posterior head. Okay, posterior head. In adults, it will be your frontal side. So always remember, you have to be able to explain or the mechanism of injury plus patient. Mechanism plus patient is equal to injury. That you have to explain. If you're not able to explain, then there is hidden injuries. Okay, obvious injuries you have learned that you can see them immediately. Also something called as lap belt sign, where if you're wearing a restraint device, seat belt, you'll have ecchymosis. In case of rapid deceleration injury, you will have ecchymosis over your lower abdomen, or redness or bruising in the shape of your lower abdomen, like a string parallel. So this can give rise to signs saying that there is underlying injury. Okay, this underlying injury could be injury to duodenum or an injury to pancreas, which are hidden. You won't find them in initial scans. It will take some time to be seen. Okay. Earlier, when they were not using seat belts, this kind of injury was not known. The injury that was more predominant was head injuries because of no restraint device. In a rapid deceleration, the person will move forward and hit the windshield. Okay. So in unrestrained patient, the injury will be injury to the face, neck, and head, CNS trauma. In a restrained patient, the chances could be your duodenal perforation or pancreas duct disruption or pancreatic trauma, and also you can have chance fracture or L2 fracture. Okay, L2 vertebrae fracture. Also, you need to remember here is these are all signs. Anywhere you have to look about abrasions and all this. Okay, this is not life threatening, right? So first, what we do is something called as primary survey. In that you need to do treat the life threatening diseases. That is, it comes down to A, B, C, D, E. Okay, you must have known this mnemonic several times, sir. Always it is important in your BLS classes, in your ACLS, in what any type of life support you need to give. This is your first systematic knowledge you need to have. Anyone can't see. Airway is very important. Airway, you can't live more than 1 minute or whatever your body before it goes to hypoxia and a brain injury, irreversible brain injury. Airway, then you'll have to see if the patient is actually breathing. B and C is circulation. D for disability or neurological impact. E for environment or exposure. So these are the basic headings of the A, B, C, D. In the recent ATLS guidelines, they have given that something's called as, they give a small c before A, B, C, D, E. C means control of exsanguating hemorrhage, control of exsanguating. That means a clear arterial injury is there. The patient is like bleeding like a pipe. You first pressure pack or do something to minimize that and go for next your ABCDs. Okay, how will you check for airway? Airway, everyone knows that the patient, if normally we are breathing and having good airway, patent. When I'm talking about good or use some other words, it means that the airway is patent. Patent means there's no kind of obstruction to your airway tract. It is clear and it is patent. So how will you assess airway? If I'm talking right now, that means I'm breathing, I'm having a patent airway, and my circulation is good. I'm in my senses. So simple thing, you can talk to a patient first. Say you try to stimulate the patient in however way it is, if it is verbal or if it is calling out, or if it's by stimulus, right? If you by pain stimuli, if you know that if the patient talks to you, that means that moment, at that moment you should also understand that the patient can change with time also. Okay, so at that moment the patient is having a patent airway, the patient is breathing, and if he answers relevant to your question, then he is also having no altered sensorium. That means his circulation is also good. So in one question you cleared ABC. It took you hardly 5 seconds to know this. Okay, but suppose you have a trauma patient, a severe trauma patient with brain injury. You have to, and his GCS is pretty low, less than 8. He is not able to talk, he is not able to react to your pain stimulus properly. You have done your GCS is a normal scale that is have responses numbered to numbered, where eye opening, you have your motor response and your verbal response as some numbers. So that numbers you need to understand. Okay, so less than 8 means it is a severe head injury. In a severe head injury, the patient is not talking to you, he is comatose. You need to just check if his airway, first is airway, right? So what will you do? You open his mouth, see for any foreign bodies or anything. Okay, then you, to protect the airway, you do is chin lift and jaw thrust. Okay, when you lift the chin and you do a jaw thrust, you also see your intraoral for any kind of foreign bodies, like did the patient aspirate on him. If suppose the patient aspirated, you take a high suction equipment and you suction out. Okay, and then you, what you do is, in such case as an aspiration or if you found food particles in the mouth, you aspirate it. Afterwards you immediately know that this patient is going to be a high risk for aspiration pneumonia. and he can't protect his airways. So what you need to protect his airways. There are few clinical indications. There no, not a few, more than a few indications for definitive airway. Okay, so what you do is, basic ones, if you don't have an equipment or anything, what you do is you do a chin lift and a jaw thrust. Okay, you also have to remember this is the trauma based, right? So until and unless your cervical spine has been cleared, that means there is no, when I use the word clear, its spine is clear, that means it has been already assessed that there is no injury. Until you have assessed your cervical spine injury, always have a collar around, or keep the head and neck in a inline stabilization. It's called inline stabilization. Okay, so after you have checked your airway for foreign body enders, you have to immediately do airway adjuvant, something called as airway adjuvant. Okay, airway adjuvant, what is the airway adjuvant you will do if the patient is not having a in the extreme of the patient where the airway you feel that he is not compromised? What will you do? You put oral airway and intubation, or first intubation followed by airway device. How will you intubate? You have to, there's something called as lemon assessment. Okay, after that lemon assessment, what you do is you either go for rapid sequence intubation. Okay, best is rapid sequence intubation in cases of emergency rather than an elective intubation. In rapid sequence intubation, you have some drugs that you give prior, like muscle relaxants and painkillers, sedatives. So you intubate the patient, and you have to remember that the tube, in the endotracheal tube nowadays we use it is a cuffed. Whenever you find the instrument in final years, if you will be shown the instrument and asked what is this instrument, then you have to tell that it is a cuffed, cuffed, cuffed endotracheal tube. Okay, they are available in different kinds of diameters. Okay, so which kind of diameter, or which kind of which number tube is uh, appropriate for what age is important, right? You can't put a smaller tube in a bigger individual and a bigger tube in a smaller individual. It won't go for a smaller individual. So the diameter of the ET tube is important, because these are all time constrained devices, right? You should also have these resources available, like in your trauma bay, and it should be done. Yes. Yeah. So with the help of your laryngoscopic blade, you do intubation. Intubation for 7.5 is for females, adults. 7.5 to 8 is adult males. Okay, and for kids and infants, it should be 1.5 or 3, in between that, till 3.5. In between that, based on your age group, it can increase up to 4.5. Always remember how the length of the ET tube inside should go is into 3 roughly. Suppose if you're using a 7 number ET tube, into 3 is 21. So roughly your carina will be in bifurcation of your trachea will be at 21 centimeters. 21 centimeters you will see at the tip of your marking on the tip of your teeth. Okay, that tube you can see there, marking of the tube at the tip of your teeth. Okay, once you have done all this, airway is controlled. You connect, airway is called as secured if you have taped this ET tube properly. Okay, and fixed it and connected it properly, because there are chances of mislodging or of the tubes. Okay, airway is done. Next, go for breathing. In breathing also similar thing. You, once you feel that airway is compromised, same thing. So in airway, one if you have achieved endotracheal intubation, then breathing you can assess by ventilator settings. if the patient is having any problem, like if he's being able to ventilate properly, or is he requiring any high PEEP or high requirement or high tidal volume or high FRC by the machine, then that means that there is also some kind of leak in the bronchial, or there might be a tracheobronchial, not a tracheobronchial, or it could be a bronchial injury. So go for a chest X-ray immediately after intubation. You'll have mobile chest X-rays in the trauma bay itself, where you just do that and see for circulation. Circulation you have to know by basic thing is by pulse. If pulse, if you're not able to feel the pulse, and then you'll have to go for the adjuvant in circulation is venous axis. So vascular axis, sorry, vascular axis. So go for vascular axis. It depends on your peripheral line. Two peripheral lines are minimum. Two peripheral wide bore. Short wide bore catheters are important peripherally, but you have to understand the pitfall is whenever we have hypotension, the veins collapse on itself. The venous walls collapse on itself. So in those times, in particularly in pediatric, in diabetics, and in patients who have smaller veins, this could be a problem. So the next options would be in adults would be go for venous cut down. Venous cut down can be if you need to do a large volume infusion, you can cut down the venous at your inner thigh, or in adults, in children, you can do it near the ankle. But the best for the children in case of trauma is interosseous axis. Okay, if you have tried to put needle IV axis in peripheral line for 3 times, or you have wasted time for 90 seconds, then go for interosseous axis. Interosseous axis, you can do it in the upper tibia, distal femur, or distal tibia, okay, or in your proximal humerus. You'll have an automated drilling machine. You use that to drill into the bone, and you can connect your IV line into the bone. Okay, that is one advantage. You can give high volume. The complications are very less with that, and you can give a high volume infusion also. The second and the last resort is, if you're not being able to get any of this, usually it is rarely done for children, but it is commonly done for adults, is central venous axis. In case of trauma, first order of preference is femoral, jugular, and then subclavian. People will tell you that femoral will contain a lot of complications, but recent studies does not support this. Okay, but you have to remember one thing that by evidence is that anytime you put a central line in an emergency department, there are high risks of contamination and the central line infection. Okay. Apart from C, then you have D, disability. You have to do a neurological examination, see if the patient has any deficits. Okay. And E is for exposures. In case of any poisoning, or in case of industrial accidents, you have to clear the patients of all his clothes. And also, once you're doing this environment, D and E, in D also you have to disability, right? In disability, in case some patients are complaining of spine pain or tenderness, then you will have to examine them. Always remember that there's a word some people will use, that is log rule. So at least 6 people are required, 6 caregivers are required to examine the back of the patient. Okay. Apart from that, in environment, you'll, after you're done with environment, at any point of time, after you're done with your primary survey, after any point of time, immediately after the primary survey is done and the patient is a little bit stabilized or responding to your treatment, then you should go for secondary survey. In secondary survey, you should find out the mechanism of injury, get a better history, what the past medication the patient used to be on, when is the last meal he had, any kind of surgeries did he have. Okay, all this kind of information you get in your secondary survey. Also in secondary survey, you should try to find out if it what are your head to toe examination. You have to look everywhere, and suppose you don't find any injury that is matching to your outcome, then you have to find out hidden injury, I said, no. So you have to have a focused exclusion approach. So the approaches are, in case you the mechanism plus patient is equal to injury does not match, then there are two approaches you should do. One is look everywhere approach and focused exclusion approach. Okay. uh, I think that's it for now. This is a brief outline. I'll just talk about two points about pediatric non-accidental injuries. In pediatric, whenever a non-accidental injury comes, the doctor has to recognize it, so that the number of times the patient comes to an ED, every time it can get severe. The next time the patient can come in a stretcher and he can die. He is already dead maybe. So you have to understand that the child abuse, if the patient is in an infant, less than 1 year of age, uh, it's the most common injury for them is always a non-accidental injury, which can stem out of domestic uh, negligence or abuse. Clinicians must be familiar with the signs of child abuse in order to protect and care for those who can't protect themselves. Often the reported mechanism of injury is low fall from crib, couch, or death while the child was unattended. The risk of deaths for infants and children up to 5 years from falls less than 1.5 meters is less than 1 in million. Okay. So if he falls from 1.5 meter high, the chances are very less. But you need to understand that repeated head trauma, posterior rib fractures, uh, and a spiral fracture of the humerus, all these things that don't explain the mechanism of injury, usually because the patient attender does not give proper history to hide the fact. So these should all give you. And also remember that posterior refractures in general are very uncommon in children because their ribs are very soft, amount of energy to break the ribs. If the ribs are broken, then there is more significant intra-abdominal or intrathoracic injury in the child. But posterior rib fractures, you have to understand that they can be fractured with a direct blow, which could be most likely be because of abuse. Okay. And also these children have higher rates of diffuse axonal injuries, subdural hemorrhage, skull fractures, and epidural hemorrhage. Okay. And in you should also learn that not only pediatrics, even the elderly people are abused in nursing care homes, where they, because they do, one is for the financial, or one second is because they are already mentally impaired, so they have negligence. You can see trauma and fragility factors. So all these things you have to remember, to so that you have to non-judgmentally speak to them. Apart from this, there is something called as IPV, intimate partner violence, which you can see in the domestic violence. It comes under social violence. Okay. So how do you incidence of this is a lot of incidents. You can see that a lot of people known to people only hurt the people. Uh, so okay, I'll tell you proper definition of intimate partner violence, also known as domestic violence, refers to those acts of interpersonal violence resulting in physical or psychological injuries to members of the same family or household or intimate acquaintance. It can also be intimate acquaintances. Okay. Remember these are just your special topics. One, your homework is research about pediatric non-accidental injuries and geriatric abuse and intimate partner violence. Okay, this is your homework. I just try to research on it, and how as a clinician you can help them out once they come to your trauma. Okay, thank you.